Hi, good afternoon, everyone. Another edition of Newton-Wellesley Medical Group Lunch and Learn. Another Thursday afternoon with a good-looking weekend up in the forecast. We're really excited to invite one of our newer staff members in the Department of Medicine in the Division of Nephrology, Dr. Marta Christoph. She joins Dr. Walt Mutter and crew, and she'll talk a little bit about her division and her office. And topic today is mineral metabolism in chronic kidney disease. As I like to do, just want to tease upcoming lunch and learns. Next week, we have the meniscus tears, fix or forget. Following that, Doug Camo, one of our sports medicine physicians, is going to talk to us about concussions, as well as coming up, Dr. Coley is going to talk to us about urinary and fecal incontinence. Want to remind people about one of our physician wellness initiatives that we're very excited about, which is our drop-in virtual meditation. I really want to remind folks that time has changed. We pushed it back. Thanks to feedback from people who were involved to 5:30 to 6. You can get that right into your calendar, so it's an easy click and go. If you're having trouble, please email Audrey. You can see her email at the bottom of this page. This is a employee perk spotlight. I haven't talked about this at Lunch and Learn. So this is about Uber Eats, and I'm sure everyone has used an Uber, and I'm sure most people have used Uber Eats, but there is a product called Uber Eats Pass, which actually gives you unlimited free delivery and 5% of all your orders over $15. Who doesn't do an Uber Eats order that's under $15, but I don't know. So to get started, you'd have to click here and then log in with your personal Uber credentials. Again, if you don't have Uber credentials, then you can sign up then, but that would be probably pretty rare. Anyway, you get the free Eats Pass, but after you log in, then go ahead and use this second URL. It's only for a month, so please, this is one of those recurring subscriptions that are $10 a month that you have 3,000 of probably, like I do, and you would want to shut it off if you're not going to be using it. But it is $10 a month, and if you use this service enough, you probably make your money back pretty fast on the 5% off all orders and the free delivery. This is accessed through instructions on here. If you have any questions, you can email me or email Audrey Bossy on that. And without further ado, Dr. Christoph.
Thank you so much. I just wanted to thank everybody again for joining us today and take a minute to introduce the group. We are Newton-Wellesley Physicians Nephrology in the Department of Medicine. I'm joining Dr. Mutter, who is the chief, and Dr. Neuringer, who's the assistant chief. And the other two physicians are Dr. Corzelius and Dr. Lundquist, who also see patients. As you may know already, we see patients with all kinds of disorders involving the kidneys, including kidney stones, chronic kidney disease, dialysis patients, and any electrolyte or acid-based problems. And so here's our contact information. We're in the green building on the 4th floor. Currently, we're doing both in-person and virtual visits, depending on patient comfort. Please send us your referrals. And if you have any further questions, this is our phone number, or you can contact Dr. Mutter or any of us. Thank you so much. Next slide, please. So what I wanted to take a few minutes to talk about is mineral metabolism in chronic kidney disease. So this previously was referred to as renal osteodystrophy. You may have potentially seen this, but 10-15 years ago, there was a recognition that the changes that occur in patients with chronic kidney disease are really more systemic and involve not just not just the bone, which is the osteodystrophy part, but also changes in calcium, phosphorus, PTH, vitamin D, as well as soft tissue and vascular calcifications. And I won't really be talking about the latter very much, except one slide at the end. But that's sort of an area that I think has a lot of potential for research and growth. Next slide, please. What I will be talking about is what happens to this axis, the mineral metabolism axis in chronic kidney disease patients, what happens to bones, which I think is something that a lot of people don't appreciate, what are we monitoring, and what are we trying to treat and how. Next slide, please. So this is a figure out of a review that also includes some hormones like FGF23 and clotho that are not in clinical practice. But I like this figure because it shows that as kidney function declines with decreasing GFR on the axis there going to the right, various metabolites will change and increase or decrease. And so, for example, you see parathyroid hormone or PTH in the green starts increasing, generally more in stage 4 CKD, and phosphate increases even later. Calcitriol or vitamin D starts decreasing perhaps earlier. And then calcium also decreases again very late in chronic kidney disease as patients are approaching dialysis. Next slide, please. And this is just another way of summarizing some of the changes that occur sort of more in a table format rather than a visual format. But what we see and what we monitor are alterations in vitamin D metabolism, and not only calcitriol, but also 25-hydroxyvitamin D, hypoparathyroidism, development of hyperphosphatemia and hypocalcemia, which I said are more late phenomena, bone disease, which I'll spend a little bit of time on, soft tissue calcifications and vascular calcifications, which we're just starting to study and try to figure out what we can do about that. Pruritus, which is a significant problem for some patients with end-stage renal disease, and that is felt to be related to phosphorus abnormalities, to high phosphorus, but it's not always the case, and it can have significant quality of life consequences. And skin ulceration, which is, I have one slide at the end. Next slide, please. So really, if you remember one thing, this is what I'd like you to remember, and that is that these abnormalities are common and in the patients with chronic kidney disease and end-stage renal disease, and they have been associated with higher morbidity and mortality in this population. This is in a data based from epidemiological studies and animal studies. And this is basically why we are monitoring the various parameters and trying to see whether or not we can alter them. Next slide, please. So I promised to talk a little bit about bone because I feel that, especially in our population, we don't discuss that as much. And the clinical outcome that we really care about is fractures in this case. And so this is from a meta-analysis of various trials and dialysis patients that the fracture incidence has increased in that population, and the mortality is higher. Mortality is high anyways in patients on dialysis, as you may know. And so to sort of on top of that, have increased mortality in individuals with fractures. It's quite significant. And certainly mortality is increased if you compare, same age group basically with fractures. Patients with dialysis will do worse. Next slide, please. I wanted to spend a minute here talking about bone and what are some of the things that we see, and just going over even a little bit of normal bone physiology, which maybe you are not aware of. So normally, bone constantly remodels. At any one time, there's sections of the skeleton that are being turned over, where their bone is broken down locally and then built up again. And in the adult, it's felt to be about 7% of the skeleton turns over per year. There's caveats, that, if you're a kid, it turns over faster, etc. But that's the average. In our patients with chronic kidney disease, there's several abnormalities that are seen in this process. One of the things that occurs, as in figure B, is that patients can develop osteomalacia. And what osteomalacia is a failure of the bone to mineralize correctly. And that is because when bone is made, there is a protein matrix that's secreted initially. And then on top of that, calcium and phosphate basically mineralize and form a compound called hydroxyapatite. And so if there's a failure of this mineralization process, then that's osteomalacia. And classically, that's what happens with vitamin D deficiency, and that's what rickets is that there is a mineralization defect. In patients with kidney disease, we do see osteomalacia, but we also see two other types of abnormalities in C and D. C is what used to be called a dynamic bone disease, and now we call low turnover disease. Basically, this normal process of repair and turnover of the bone is very much reduced. Not very much happens in the bone. And so the normal repair mechanisms are basically quiescent. And it's felt that for that reason, this type of low turnover disease may be more associated with fractures. On the flip side is a high turnover disease, used to be called osteitis fibrosa. This is an old slide. And osteitis and high turnover disease is exactly what it is. Instead of only a fraction of the skeleton being affected, a lot of skeletal surfaces are undergoing turnover at the same time, and some of the bone that's laid down is not very normal, basically, and it's weaker. And that generally is associated with high PTH, this high turnover disease. Next slide, please. And what I wanted to do here is I wanted to basically summarize and say a word about, what do we think some of the factors are that affect us, and just to illustrate why it's difficult for us to say for a given patient what exactly is happening at the level of the bone. So if you have a patient that's starting with whatever their chronic conditions are, like at the top, they have osteoporosis or they had steroids or etc. And then they start developing CKD. The idea is that initially the bone either slows down turnover or it becomes less elastic and there's changes in quality. And then as CKD progresses, there is also loss of quantity of bone and turnover can be high or low. And these are because of associated electrolyte abnormalities like hyponatremia, acidosis, hypogonadism, inactivity, and then also this mineral metabolism axis abnormalities, PTH changes. Diabetes actually plays a role as well. And so in the end, our patients have both bone that's of lower quality and a reduced amount in some cases, and therefore they have this increased fracture risk. Next slide, please. And I just put this slide to illustrate that this is somewhat older data, but these are bone biopsies. This is looking at the type of bone phenotype in patients with chronic kidney disease. And I'm just illustrating that if you biopsy patients with chronic kidney disease stages CKD at 3 to 5, less than 20% of biopsies will show normal bone physiology. And if you biopsy patients who are on dialysis, so that's what's shown on the left there. And the red triangle represents the normal biopsies from the pie chart. And if you biopsy patients who are on dialysis, even fewer biopsies will be normal. And so it's a pervasive problem. Our difficulty is that the bone biopsy is an invasive procedure and not done clinically very frequently. And so we don't really, for a lot of patients, know exactly what's happening. We know that these things are going on. We just are not able to track them very effectively. And that's a ongoing area of research to develop serological markers or some kind of a imaging modalities that would help us understand this better. Next slide, please. So to summarize this part, with respect to the bone, newer guidelines suggest that DEXA screening is acceptable in patients with CKD. Previously, it was not recommended. Now the society has come out and said that a low T-score likely predicts fractures. There may be other screening modalities that may be more useful later on, but for right now, DEXA is acceptable. With respect to treatment, the recommendations are that if people have a normal PTH and basically a normal mineral metabolism profile, then they can be treated as osteoporosis patients with bisphosphonates or whatever the therapy that you normally would choose for a patient of that age and that T-score. The difficulty is that if people already have more advanced CKD, then I think that it should be a case-by-case basis, and they should be referred either to an endocrinologist or to a nephrologist for more case-by-case therapy. And denosumab is one medication that has been used with patients with CKD, although it has hypocalcemia as a side effect. And the only study that has really conclusively shown in patients with advanced CKD or end-stage renal disease any fracture reduction is the EVOLVE trial, which suggested that in older patients, cinacalcet therapy may reduce fracture. So that's the only drug that we know of, but we don't routinely put patients on it for fracture prevention. We put them to treat the PTH, basically. Next slide, please. So this is just a phosphorus. I will add phosphorus in here. This is just to summarize a number of epidemiological studies that have suggested that or associated, higher phosphorus linked with increased both cardiovascular and all-cause mortality in CKD and end-stage renal disease patients. Low vitamin D similarly increased mortality and CKD progression, higher PTH. And so the difficulty, though, is that because of this endocrine feedback loop where PTH affects calcium and phosphorus and vitamin D and vice versa, it's hard to know and devise trials where only one of these parameters is addressed. Because if one of them is addressed, others will also change. And with the exception of PTH, there's really no strong data from trials, partly because of this limitation that correcting a particular imbalance will improve mortality. We can improve surrogate markers like phosphorus levels, calcium levels, PTH levels, but sort of hard outcomes, we are still lacking. We are doing our best currently in trying to, mitigate these changes with the hope that it is, in the end, helpful to the patient. Next slide, please. I wanted to say a word about phosphorus. Because this was partly an area of interest of mine, and that is to say that especially for patients with late CKD and dialysis, phosphorus derived from the food is becomes highly important in trying to manage that. And phosphorus bioavailability, meaning how much of that mineral does the body absorb, highly depends on the source of food, basically. And so inorganic phosphorus, which is found in food additives or preservatives, is 100% bioavailable and will be absorbed right away. whereas phosphorus that is from plant-derived foods from plants and is much less bioavailable. And so one of the recommendations that I have for patients with CKD, especially later stage CKD, is to try to start shifting their diet, at least partly, towards a more vegetarian-based or diet with plant-derived sources of protein, at least in part, to try to manage the phosphorus level. Next slide, please. And so this is the summary with respect to phosphorus and PTH. And I should say that all of these metabolites really, but especially phosphorus and PTH, we try to do serial assessments because we know that phosphorus, for example, there's diurnal variations in the levels. PTH, we know that its levels can actually change minute to minute and normally, and so it is never one value that we take to respond to, and it's so we have to measure it through time. As with phosphorus, as I said, plant-based diets are favored, and generally we do not treat hyperphosphatemia unless extremely high in patients who are not yet on dialysis, and then there we try to limit the amount of calcium-based binders. And for those of you who don't know this, binders are basically medications that are not absorbable that patients take with the food in order to absorb phosphorus, basically from the diet in the gut and prevent it from being absorbed. And then same with PTH, that we base our decisions on serial assessments, and then we try first to modify vitamin D, supplement vitamin D, and then modify phosphorus with the diet changes that I suggested. And it's only if it's elevated persistently in late CKD, then we feel comfortable treating it with either calcitriol or cinacalcet. And there was a subsequent analysis of a large study that looked at PTH, actively lowering PTH and mortality, and the primary outcome was actually negative, not significant, but subsequent analysis suggested that some types of cardiovascular events may be prevented by treating PTH, and so that's why the statement is there, is that potentially lowering PTH may improve mortality. But again, it was not a primary outcome of a study, but subsequent analyses. Next slide, please. Same thing with calcium and vitamin D. Serial assessments, hypercalcemia we try to avoid because of the vascular calcifications that we see in our patients, and vitamin D levels that generally the target is greater than 30. And that potentially can improve PTH because of these loops, as I spoke about. And so in our patients, so that's what you will see that we screen for: PTH, vitamin D, phosphorus, calcium as part of the chemistry panel anyways. And then we will try to address the vitamin D deficiency and potentially diet changes in most CKD patients. Next slide, please. So I have only a couple of more slides, and basically this is talking about this devastating and rare complication. This is calcypholaxis. If you have seen it before, you would remember it. And this is very high mortality within the first year. Usually it's in the soft tissues, upper thighs, abdomen. And it's mainly seen in patients with end-stage renal disease, although occasionally patients with CKD, and I'm aware of at least one case in somebody with normal renal function, actually. Next slide. And it was felt to be for a long time secondary to severe hypoparathyroidism in this population, and then More recently, there's some data suggesting that really skin trauma, repeated skin trauma may predispose to this. And so patients with diabetes who are injecting insulin may be at a particular risk. But again, this is a relatively rare phenomenon. And I will say that at the Mass General, there is a registry study ongoing. One of the members of the nephrology department there is leading this, trying to understand more about this, very high morbidity and mortality disorder. And I just wanted to mention it because it's part of this picture. Next slide, please. So this concludes my talk about changes in mineral metabolism and some associated changes in bone and in calcifications in patients with chronic kidney disease that we try to monitor and prevent if possible. Again, I wanted to highlight our group in nephrology in the Green Building on the 4th floor. Led by Dr. Mutter, who many of you have probably met or interacted with already, and also Dr. Neuringer, Dr. Korzelius, and Dr. Lundquist. I will take questions.
Thanks so much, Martha. That was really great. I don't see any questions. I'm going to take advantage of the 2 or 3 minutes left and just kind of ask you a question from a PCP point of view. As we start to see our patients move into 3A, 3B, and then to stage 4, it's not uncommon for us to kind of check the PTH, the vitamin D, and the calcium. And I've always been under the impression is that you try to increase the vitamin D to lower the PTH to preserve the bone.
Yes.
That may be a simplistic PCP view of it, but that's kind of the way I've always thought about it. Is that?
Absolutely. I think that that's exactly what we do as well. There is some studies that are suggesting that in earlier stages of CKD, you can lower the PTH by improving vitamin D. Exactly.
That's where I was going. So yeah, so you would, 30 is the cutoff we use a lot. Would you tend to throw folks in the 30s and even in the low 30s on 50,000 a week, or would you still kind of hold off on that until they progressed?
So personally, I would say if they're less than 30, I would definitely give them 50,000 a week. If they're in the low 30s, I would probably ask them to take a daily, 2,000 units. I don't know about this particular assay at Newton-Wellesley, but previously, for example, I know that the assay for vitamin D has like a plus or minus 5 confidence interval. And so therefore a value of 30 could be 35 or could be 25.
Right.
And so, so there I would potentially be cautious, but recheck it, in like a couple of months just to see where things are.
And then real quick, I know there was a nice comment about the diet, because I get a lot of questions in my patients who are in the 3B, 4 range about what they should do about their diet in general for chronic renal disease. I know you refer some folks to dietitians, et cetera. Can you give 2 minutes for the PCP about diet? What do you tell your patients about diet restrictions before dialysis?
Yeah, so that's before dialysis, right? Yeah. So, most patients, I tell them not to limit protein per se. I mean, certainly people who are on protein shakes or various things like this, I ask them to avoid that. But generally, I think that unless it's very late CKD, protein restriction is not needed.
Oh, feel like you froze up on us there. So I caught the protein restriction was not needed. I guess we'll have to leave it at that. Thanks everyone for coming on. I hope everyone has a really nice weekend and gets out and enjoys some sunlight so they can increase their own vitamin D. And there you are. You want to finish your thought? Go ahead.
Yeah, I guess my internet's not so great. Yeah, so no protein restriction. Only advice based on if the potassium's high, low sodium, and otherwise try to switch to more vegetarian-based diet for the phosphorus.
More vegetarian-based diet, okay. Yeah. Well, I guess we always try that. It's worth another shot at some point. Thanks again for doing this. Hope everyone has a nice weekend, and we'll see you all next week for a talk on meniscal tears.
Thank you very much.
Yeah, you're welcome.